Thank you for listening through that the first lecture, which is on basics of MR physics. This is now taking some of that physics knowledge and applying it towards image optimization. So shown here is all the things, or many of the things, that factor into image optimization. There's the magnetic field strength, which in clinical care right now is usually 1.5 T or 3 T. There's the alphabet soup of sequences: 2D spin echo, 2D fast spin echo, 3D fast spin echo, stir, etc., etc., etc. Although a shout out, I think most of you know, but maybe some of you don't, that stir was invented by Graham Bitter, who's one of the professors, one of our faculty here in our department, so maybe some of you don't know that. But sequences are relevant to image optimization. For each one of these sequences, we might have multiple different options and parameters: the use of contrast agents, the repetition time, the echo time, the flip angle, the bandwidth, etc., etc., etc. And the combination of these things results in image quality. So things that, all other things being equal, make image quality better are the signal-to-noise ratio, the contrast or contrast-to-noise ratio, spatial resolution, sharpness, coverage, and things that degrade from image quality or degrade from the patient's experience: acquisition time, artifacts, and spatial distortion. So we're often trying to apply different sequences with different options and parameters while taking into account the magnetic field strength in order to maximize the stuff in green while balancing and trying to minimize the stuff in red, and it's always a compromise. Now, one thing I mentioned at the last lecture, but let me emphasize it again, is that 3T compared to 1.5 T will have approximately twice the signal-to-noise ratio, but it will also have twice the artifact-to-noise ratio. And that makes sense, right? Because if something's going to double the true signal-to-noise ratio, then it should also double the spurious signal-to-noise or artifact-to-noise ratio. So just keep in mind that 3T at its best is better than 1.5 T. 3T at its worst is likely to be worse than 1.5 T at its worst. At any rate, this is a very intimidating list of things. So, a few bullet points. Do the correct exam. So you can learn all of this image optimization, but if you do the wrong exam, it doesn't matter. So the reason I'm emphasizing this is I don't want you to feel overwhelmed by all of these sequences and options and parameters. Common sense will carry a lot of the quality that you do. So do the right exam. Prepare your patient. Have you or the technologist explain to the patient what they're going to experience. Go over some breathing instructions, etc. Because again, 95% of MRI is not all the details. It's doing the right exam, it's preparing your patient, and it's positioning your patient and the coils. So let's just go over a couple of these real bread and butter things before we dive into the details. So this is what I mean by patient preparation. Here is a normal volunteer that we scanned maybe in 2007, 2008, and there's all of this artifact coming from the back. Any idea what this artifact is? So these are tiny little clips from a bra. So prepare your patient. So women should either have bras with no metal clips or just no bra. So that is just patient preparation. And when you remove the clips, then you get images like this. So with no knowledge of physics, with no knowledge of all of that complicated stuff, simply preparing your patient takes you from images that are almost uninterpretable to images that are of reasonable, good quality. Here's another thing. If the patient can hold their breath in expiration, images are of higher quality than if they can only hold their breath in inspiration. Here is a patient who can actually hold her breath for 30 seconds very comfortably, very comfortably. But when she holds her breath in inspiration, even though she's actually comfortable, her diaphragm is quivering just a little bit, and it causes the images to be a little bit blurred, whereas when she holds her breath in expiration, look how much more sharply you can see this lesion. Look how much more clearly you can see the blood vessels in the liver, as well as this background of regenerative siderotic nodules. So if your patient can hold his or her breath in expiration, do your breath holding in expiration. What do you do if they're too uncomfortable to hold their breath in expiration? Well, option one, you tell the patient, too bad, you're going to be uncomfortable. Or option two, you say, I don't want you to be uncomfortable. I want you to have a pleasant experience. Hold your breath in inspiration. What do? Common sense. You have your patient hold his or her breath in inspiration. But if they can hold it in expiration, do it in expiration. Location, location, location. Doesn't matter how smart you are with your MR physics. If you put the coils in the wrong place, you're not going to get good imaging. So once upon a time in body imaging, we used to do brachial plexus MRI, and here we were trying to look at the nerves coming through the axilla. And initially we placed the coil. By the way, the coil is basically like an antenna, so it's what's listening to the signal. We put the coil up here by the upper arm when we were interested in the axilla, and then all we do is just reposition the coil, and then we see the area of interest. So if you do those three things, order the right exam, protocol the right exam. If they want to do a liver, do a liver. If they want to do a prostate, do a prostate. Put the coils in the right place and prepare your patients. You can stop listening now, and 95% of your exams will come out okay. So everything I'm going to say for the next 45 minutes is to get that next 5%. We're now at 95% quality simply by doing the right exam, preparing the patient, and putting the coils in the right place. By the way, how often are coils in the wrong place? I would say, I haven't measured this, I should do this. In fact, Sudha, this will be your next study, and you're going to very pleasantly say, Dr. Sirlin, of course, I would love to do this study. We should actually figure out how often coils are not in the optimal place. I bet it's 40% of the time the coil is not optimally positioned, meaning that if you're doing a liver MRI, the coils are not actually going from above the liver to below the liver. If you're interested in something really unimportant like the brain, then the coils are probably not perfectly covering the brain. Now maybe in brain it's different, but in the abdomen, I bet 40% of the time the coil, oh, I'm sorry, the brain is the most important. I'm just teasing, My brain is not that important, but for most people, okay, I'm just speaking for myself. Okay, so what we're going to do now is quickly go over this table, and then for the rest of the lecture, I will go over pieces of the table. So this table is very, very intimidating. It's intended to be very intimidating, and so we're going to try to simplify it. And what we're doing here is we're going to look at the effects of either applying or increasing the following parameters. So if you apply or increase gadolinium, so if you give gadolinium, or increase the repetition time, or increase the flip angle, or the echo time, or the bandwidth, or the slice thickness, or the number of frequency encodes or phase encodes, or number of slices on a 3D acquisition, or if you apply parallel imaging, or if you increase the B value. So these are the parameters we're going to be manipulating. What happens to signal to noise? What happens to your minimum TR and TE? What happens to your acquisition time? What happens to your image sharpness? What happens to your T1, T2, and diffusion weighting? And what happens to artifacts, chemical shift of the first kind, susceptibility, and distortion? So these are the parameters we're going to apply. These are the effects we're going to look at. And this table is fairly complete. We're not going to go over all of this table today because it would be overwhelming. But if any of you want to afterwards look at this table, start thinking through it, some of it might make sense to you, some of it might not. We can potentially have a little follow-up, little seminar on this and start teasing each one of these things. But in the interest of time, we're not going to go into a lot of detail onto all of these things. So this table is here for sort of your review, but we're not going to go through all of it. Other than very quickly, I'll go through all of it right now, and then we'll slow down and go through a few key elements more slowly. So here is the whirlwind. So again, don't become overwhelmed. I'm going to go through this pretty quickly, and then later you can go over it at your leisure. So the quick review comes now. When you give gadolinium, all other things being equal, you increase your signal to noise, you decrease your T1, and you decrease your T2. Now let me pause there for a second. You cannot shorten T1 without shortening T2. You cannot shorten T2 without shortening T1. So gadolinium shortens T1 and T2, and it causes things to recover faster. It causes things to lose signal faster. We'll talk more about that in the next lecture. All other things being equal, if you increase your repetition time, you increase your signal-to-noise ratio, you increase your acquisition time, and you decrease your T1 weighting. So when you increase the TR, your T1 weighting goes up. Your T1 weighting goes down. Acquisition time goes up. Signal-to-noise goes up. Flip angle. When you increase your flip angle, your signal-to-noise increases until you get to the so-called Ernst angle. We'll talk about that later. And then your signal-to-noise goes down. So there's an optimal angle called the Ernst angle or optimal flip angle that will maximize your signal-to-noise. When you increase your flip angle, you may increase your minimum TR. So when you increase your flip angle, depending on the sequence, your TR might go up. And if your TR goes up, your acquisition time might go up. And as you increase the flip angle, the T1 weighting goes up. So low flip angle, low T1 weighting, high flip angle, high T1 weighting. We'll talk about more of this also later. TE. When you increase your echo time, all other things being equal, your SNR goes down. If you increase your TE, then by definition, you've increased your minimum TE. If you've increased your minimum TE, your minimum TR also might increase, which means your acquisition time might increase. If you increase your TE, your T2 weighting increases, your image becomes more T2 weighted, and you have more susceptibility and possibly more distortion on the images. And we'll talk more about this as well in a moment. Bandwidth. When you increase your bandwidth, your signal-to-noise goes down. You can sample the echo more rapidly, so your minimum TE can go down. If your minimum TE goes down, then your minimum TR can go down. If your minimum TR goes down, your acquisition time can actually decrease. So increasing the bandwidth can actually decrease your acquisition time. More importantly, increasing the bandwidth makes your images sharper, and we'll show some examples of that. Increasing the bandwidth will decrease your chemical shift and may decrease your susceptibility. And we'll go over some of that as well later. Now here is something we're not going to review again, so I'll mention it now. Slice thickness. If you increase your slice thickness, your SNR goes up. Interestingly enough, if your slice thickness goes up, sometimes your minimum TE can go down because the slice thickness gradient is easier to apply. And if your minimum TE goes down, your minimum TR goes down. If your minimum TR goes down, then your acquisition time can go down a little bit. Your image sharpness goes down because your spatial resolution is worse, and your susceptibility and distortion can go up. Number of frequency encodes. If you increase the number of frequency encodes, your SNR goes down. It turns out that because it's more taxing on the machine to increase the number of frequency encodes, your TE might have to go up. If your TE goes up, then your TR might go up. And if your TR goes up, then your acquisition time might actually increase a little bit. Your spatial resolution is better, so your image sharpness is better. Because your voxels are smaller, your chemical shift artifact of the first kind is better. And in general, because your voxels are smaller, your susceptibility and distortion go down, with the exception of EPI-based sequences such as DWI, and we'll show examples of this later. With DWI, if your number of frequency encodes goes up, then you actually might have more distortion. And we'll go over that again a little bit. Number of phase encodes. As the number of phase encodes goes up, the SNR goes down, the acquisition time goes up, the sharpness increases, and same as with the frequency encodes, in general, susceptibility and distortion get better, except for EPI diffusion, in which your distortion gets worse. Now here's something that's interesting. If you're doing 3D imaging, like lava, and you increase the number of slices, you actually get higher signal-to-noise ratio. Your acquisition time also goes up, and we'll review that as well. If you apply parallel imaging, your signal-to-noise goes down. Because you're acquiring fewer phase encodes, your acquisition time usually goes down. Turns out that because you have less T2 blurring, your sharpness improves. And because you have shorter echo trains, your susceptibility and distortion can go down, especially with DWI, and we'll show that as well. B value affects the diffusion, and if you increase the B value, your signal to noise goes down, and we'll go over that again. Your minimum TE goes up, and in the next lecture we'll explain why. Your TR therefore might go up. Your acquisition time therefore might go up. And another thing that happens when you apply a B value is you get more diffusion weighting, but you also get potentially more distortion. Okay, so I realize that for some of you this was a review, for some of you this was a bunch of just mumbo jumbo, and for some of you it might have been somewhere in the middle. What I'd like to do now is we'll now go back to each one, not each one of these rows, but some of these rows, and dive a little bit deeper into them. And for some of them we're not going to go over them again. So this table is a table that I'm happy to share with you, and at your leisure over the next year or so, or when you do your MR rotations, whether it's on body or neuro, whatever, you can kind of go over this table and see if you can start making heads or tails out of it. And if you can't, I'm happy to meet with you one-on-one or in small groups to go over this table in more detail. And there are some of you maybe who like to have a black box approach to things and don't necessarily care to understand things necessarily, as long as you can apply them. And so if you're one of those people, feel free to just apply these rules even if they don't completely make sense to you. Okay, but let's just talk very quickly about gadolinium. We'll talk more about gadolinium in a moment. So gadolinium, all other things being equal, increases your SNR and decreases the T1 and T2 relaxation times. So gadolinium always shortens the T1, and depending on your imaging sequence, that may or may not improve the T1 weighting. Gadolinium always shortens T2 and T2 star, but depending on how much gadolinium you gave, and depending on the sequence, it usually will have minimal effects on T2 or T2 star weighting imaging. Gadolinium has almost no effect on diffusion. It does increase the signal to noise of T1 weighted imaging. So we'll talk more about gadolinium in the next lecture, but for now, here's just a couple of examples. So here's a patient who is imaged pre and post gadolinium, an out-of-phase set of images on your left, an in-phase set of images on your right. So let's look at the in-phase image. Notice that the liver is bright because the liver has, this is a T1 weighted image, and because the liver has a short T1, the liver looks relatively bright compared to the kidney. on this T1 weighted image. So the liver has a shorter T1 than the kidney. But notice that the liver is clearly darker than the fat because fat has even shorter T1 than liver. You then give gadolinium, and now notice that the liver is almost as bright as the fat. In fact, like if you look right here, here's fat, here's liver. They're essentially the same signal, aren't they? In fact, right here, one could even argue that the liver might be a little bit brighter than the fat around the kidney. Now, why is the fat here so bright compared to here? Because on MRI, we use coils. And so the coil is like an antenna that we place on the skin. So there's a lot of signal coming from the fat here because the coil is right here where my arrow is. Notice that the coil is further away from this fat, so that's why this fat looks darker than this fat. But look how the liver, which clearly was darker than the fat pre-gadolinium, is now almost as bright or even brighter than the fat. Same thing for the kidney. The kidney was much darker than the fat, and now after giving gadolinium, the kidney is almost as bright as the fat. So gadolinium causes T1 of water-based tissues to shorten. The gadolinium does not affect the fat, and so the fat is unaffected. Now this liver is fatty, so that's why on the out-of-phase image, the liver looks darker than it does on the in-phase image. And the reason that we have black lines at the interfaces of the solid organs like the kidney and the surrounding fat, or the liver and the surrounding fat, is because of chemical shift artifact of the second kind. And when I give gadolinium out of phase, the liver gets brighter and the kidney gets brighter. Now this is what I mean by gadolinium and signal to noise. So here is a liver, and here is a liver. These images were acquired with exactly the same sequence, same parameters, same coil, same everything. So which image has higher signal to noise, this image or this image? And by the way, these images are windowed and leveled exactly the same. So you can see that pre-gadolinium, there's so little signal coming from the liver that with this particular window level setting, you can barely see the liver. Same exact window level setting, now look how bright the liver is. Now for extra credit, I'll just ask a rhetorical question. What contrast agent was given? I'll let you think about it for a moment. And the answer is that this was gadoxetate or Eovis, because the liver is now very, very bright and the blood vessels are dark. We'll talk about that later, why that might be. So we gave gadoxetate. And now for another extra credit question, what liver mass is this? And the hint is I was very careful not to call this a tumor, because this is not a tumor. This is a benign, it's focal, it's nodular, and it's hyperplastic. So this is a focal nodular hyperplasia, and we'll talk more about that later as well. Now I said that gadolinium has very little effect on T2 weighted images, and what I should have done is I should have covered up the pre and the post, because I think all of you can probably figure out now that this one was the one post-gadolinium and this is the one pre-gadolinium. And can anyone see any differences between these two images? So there's one difference between these two images. I'll also give you a clue. This was given with gadoxetate or Eovis, and there's one structure that looks different other than the stomach. Ignore the stomach. There's one structure that looks different between this image and this image. Dr. Fazeli, what structure looks different? The bile ducts look different. So notice that here the bile duct is bright, and here the bile duct, you can't see it. What happened? Did the bile duct disappear? No, we gave Eovis, so there's Eovis in this bile duct, and Eovis causes T2 shortening. So on a T2 weighted image, the bile ducts look dark, but other than the bile ducts looking dark, you can see that there's really no difference between these images. So what's the take-home message? The take-home message is that you might as well get your T2 weighted images post-gadolinium. No reason to get them pre-gadolinium unless you're doing a T2 weighted MRCP, and you need your bile ducts to be bright. But if it's not for that, you might as well get your T2 weighted images post-gadolinium. Now, this is just another individual, and just to visually look at the effect of gadolinium on various sequences. So here we have out-of-phase imaging, in-phase imaging. Here we have T1 fat-suppressed images, and here we have T2 weighted images. And so you can sort of see that gadolinium does not affect T2, but gadolinium does affect T1. These three images look very different than these three images, but this image essentially looks the same as this image. Gadolinium also has very little effect on diffusion. So this is pre and this is post, B0, B50, B500, B1000. Again, I should have covered this up because most of you can now guess that these were done before and these were done after gadolinium. But if I hadn't labeled these pre and post, could you have guessed which ones were done before and after gadolinium? I think the answer is no. So the take-home message is, might as well do your diffusion-weighted imaging post-gadolinium. There's no advantage to doing it pre-gadolinium. Gadolinium shortens T1 and T2. So now we're going to look at curves like we looked at the last lecture. So here is M naught, equilibrium T1 relaxation, signal intensity starting at 0. So if we don't give any GAD, this is the T1 relaxation of the tissue. If we give a little bit, but we're not going to image forever. We're going to image at a certain repetition time here. So this is how much signal we have at a given TR without giving gadolinium. But we don't image here either, do we? We wait for a certain amount of time called the echo time. And signal gets lost during this time, and we're going to image right here at an echo time of TE. So this is how much signal this tissue will have given no gadolinium, this TR, and this TE. This is how much signal we'll see from that tissue. Let's give a little bit more gadolinium. Or let's give some gadolinium. So the gadolinium will cause this tissue to relax more quickly, but the gadolinium also shortens T2, so it will cause the signal to lose more rapidly. And so this is how much signal we will have when we give a small amount of gadolinium. More signal than we had without any gadolinium, assuming this is a T1 weighted image. Let's now give more gadolinium. Well, we now recover even faster. This is a medium amount of gadolinium, but we lose signal faster. And so notice that going from low gadolinium to medium gadolinium, there was just a little bit of an incremental gain, but not much, was there? Well, let's give even more gadolinium. Well, now we reach relaxation, but we lose signal more rapidly. So notice that going from medium gadolinium to high gadolinium, we actually have less signal than if we had just given a medium amount of gadolinium because we lose the signal. Well, let's give a lot of gadolinium. Let's give a gallon of gadolinium. So we give a gallon of gadolinium. But now the problem is that we reach full relaxation, but now we lose all our signal. So if you give a gallon of gadolinium, not only do you kill your patient, even worse, you have bad image quality. So if you want to visualize gadolinium, use the shortest TE possible. So here are the different curves. We want to get this TE down because if we can lower that TE, then we get more signal. And notice now, well, maybe I should have drawn this so that we'd have even more signal from this gadolinium. But the point is that when you give gadolinium, use the shortest TE possible because gadolinium causes signal loss. If you can make your TE super short, then your gadolinium weighted images will be of higher quality for the T1 weighted sequences. Okay, let's talk about TR. Increasing the TR increases the signal to noise, increases the acquisition time, decreases the T1. In addition, with increased TR, you can increase your coverage, assuming you're doing 2D multi-slice images. For some of you, that was mumbo jumbo. For some of you, you understand it. If it was mumbo jumbo, don't worry about it. Come to me later. We'll talk about it. If it wasn't mumbo jumbo, then you know it. Okay. But what I want to talk about is the effect of TR on SNR and T1 weighting. So this is a normal volunteer. Well, when I say normal, I mean she's physically healthy. She may not be normal because although I won't mention any names, by the way, she's one of my favorite people in the whole world. But what this woman did is she was willing to be scanned for about 6 hours for your benefit. Okay, so I've been showing, and I will continue to show, images of this incredible volunteer who was willing to be imaged with all sorts of different permutations and combinations for your educational benefit. All right, so here we have this wonderful person who we imaged with a TR of 10, 20, 40, 80, 160, and 320. So notice that increasing the TR increases the signal to noise, right? With a TR of 10, you barely see anything. With a TR of 320, you now have lots and lots of signal. So increasing the TR, all other things being equal, increases your signal to noise ratio. But what does it do to the T1 weighting? Notice that the T1 weighting goes down because by the time you get to a TR of 320, right, the liver, the pancreas, the kidneys, the spleen, the fat, they all sort of look together. So there's a lot of signal here, but it's a pretty featureless image. Compare this image, say, to this image or this image, where now look how much brighter the fat is than the liver. So this image has a much more T1 weighting, but much lower signal to noise. This image has much higher signal to noise, but much lower T1 weighting. And so this image is not very good because it doesn't have enough T1 weighting. This image isn't very good because it doesn't have enough signal. And so your optimal is probably somewhere around here where you have quite a bit of T1 weighting and you have enough SNR. And now just to show you how much T1 weighting I have here, let me just change the window level settings. And now you can see just how much contrast there is, say, between the liver and the surrounding fat. And again, I would say the optimal images will probably have a TR of about 80 or 160. This image has the highest SNR. You look how bright it is, but not much in the way of T1 weighting. So basically what we just showed is that when you have a very long TR, so here's different tissues, a tissue with a long T1, a tissue with an intermediate T1, short, very short, ultra short T1s. So notice that when you have a very long TR, there's no difference in signal between tissues that have intermediate, short, very short, or ultra short T1s. They all look the same. So very long TRs, the only contrast you see is between these tissues and tissues with a very long T1. On the other hand, notice how much signal to noise you get, right? Look how much signal we get when we have a long TR, lots and lots of signal. What happens when we shorten the TR? Well, you can imagine when you shorten the TR, you're going to start seeing more contrast between these things, but depending on the tissue, you're going to start seeing less signal. So let's see what that looks like. Oops. Okay, it doesn't work. Okay, never mind. That's why it didn't work. I went the wrong way. Okay, so what I'm showing you now is what happens when you decrease the TR. When you decrease the TR, now you have a lot more T1 weighting, right? Now this tissue, this tissue, this tissue, this tissue, this tissue, which previously all looked the same, now look different. But notice that some of these tissues have much lower signal than they did here. So, and then increasing the TR increases the signal to noise. You see the signal's going up, but the contrast is going down. Okay, let's move on to flip angle. So flip angle has this Ernst angle that we need to talk about, and it also affects the T1 weighting. So flip angle will may increase your minimum TE. We can talk about that some other day. If it increases your minimum TE, it increases your minimum TR. If it increases your minimum TR, your acquisition time may increase. We can talk all about that some other day. Let's focus on the T1 weighting, the SNR, and the Ernst angle. First, our wonderful volunteer. Flip angle 1, flip angle 5, flip angle 10, flip angle 25, flip angle 50, flip angle 75. I hope I can convince you that flip angle 1 doesn't give us a lot of signal to noise. If anyone disagrees with me, please stand up. I think we can also agree that flip angle 5 has more signal than flip angle 1, but not a lot more, right? And I think we can agree that flip angle 75 has the highest T1 weighting. Look how much different the liver is, say, than the surrounding fat. But probably doesn't have the highest SNR. The highest SNR is probably right here with a flip angle of 50. And that was a 2D weighted sequence. Let's do the same thing with a 3D weighted sequence. Flip angle 1, flip angle 5, flip angle 10, flip angle 15. I think we can all agree that flip angle 1 has the lowest SNR, and that as you increase the flip angle, you increase the SNR and you increase the T1 weighting. And now what I want to show you is a flip angle of 10 versus a flip angle of 15. And what I'm trying to show here, this is actually the same images here, what I'm trying to show is that a flip angle of 10 has higher SNR than a flip angle of 15. Now I know that you probably don't believe me. So now you probably still don't believe me, right? You probably still don't believe that a flip angle of 10 has higher signal to noise than a flip angle of 15. Now these images were acquired with exactly the same everything except for the flip angle. So let's take a piece of this liver now and put it onto here. Now I think you can agree now that this liver is darker than this liver. So the point is that this image with a flip angle of 10 had a higher SNR than this liver with a flip angle of 15. What I want to show you now is Dr. Fazeli's favorite organ, which is not the liver, but it's a little structure within the liver. And I want to show you that although increasing the flip angle beyond 10 might decrease the SNR, right? So increasing the flip angle beyond 10 might decrease the signal to noise, but increasing the flip angle might increase your T1 weighting. And so to show that, we gave this volunteer EOVIS. And what I want to magnify now is the bile duct. So you can barely see the bile duct here, being brighter than its surrounding structures. But with a flip angle of 15, you can't see the bile duct at all, right? Or barely see it. So even though a flip angle of 15 might have higher SNR than a flip angle of 25, a flip angle of 25 might have higher T1 contrast. Now these images were not acquired with the same, I didn't create these images with the same window settings. I optimized the window settings individually to try to maximize the visualization of the bile ducts. And you can see that even trying to optimize it, I couldn't see the bile duct very well here. Okay, so what's this phenomenon? Okay, so the phenomenon we're seeing here is this equation, which all of you must memorize because you cannot be a radiologist without memorizing this equation. Okay, anyone who's finished their fellowship and is in academics or in community practice can tell you that they use this equation all the time. So this is the equation for the gradient echo equation. So gradient echo images follow this equation. Notice that the signal intensity is a function of the flip angle alpha, the TR, and the T1, as well as nasty little things like sine and cosine. So this is pretty horrible, right? But you can plot this on Excel. And when you plot this on Excel, you will get equations that look like this. So all I did now was plot that horrible equation on Excel and create a few curves. So on these curves, I'm going to show the signal intensity on the y-axis and the flip angle on the x-axis from 0 to 90. And let's start with a TR of 5 milliseconds. So I have a sequence that has a TR of 5 milliseconds. And let's say I'm looking at a gadolinium-enhanced tumor that has a T1 of 100. What will that look like? Well, if you plot that equation into Excel, you will see something that looks like this. And notice that the signal starts out at 0, it goes up, and then it goes down. And it has a peak. And the peak, the highest SNR for this particular gadolinium-enhanced tumor, is the Ernst angle, governed by that equation, and you can see I should have drawn it for you exactly, but you can see that it's probably about 10 degrees. If you sort of mentally figure out where that vertical line is from 0 to 90, it's probably about 10 degrees is probably the optimal flip angle for that. And here's Dr. Ernst. Now what about if we have a different tissue? A tissue with a T1 of 200, like maybe the surrounding adipose tissue. For the surrounding adipose tissue, notice that we also have a peak. This peak is a little bit lower. This peak might be, I don't know, 8 degrees. And notice also that its peak is lower. So all other things being equal, a tissue with greater T1, with slower T1 recovery, will have lower signal. And there's its peak. What about a tissue with a T1 of 600, like the liver before giving gadolinium? What does this tissue look like? Well, this tissue looks like this. Notice that its optimal flip angle is even lower. Its optimal flip angle might be 5 degrees. And its peak signal is lower. So take-home messages. When you have a low TR, like 5 milliseconds, then the optimal flip angle, if you're trying to image a gadolinium-enhanced tumor, is probably about 15 degrees. And if what you're interested is in imaging unenhanced liver, then your optimal flip angle is probably about 8 degrees. Okay. But if you give gadolinium, you can convert a tumor from this to this. So you can also think of this as unenhanced. You can also think of this as an unenhanced tumor, and this is a gadolinium-enhanced tumor. So notice that gadolinium causes the tumor to look brighter, and gadolinium also causes you to pick a slightly longer flip angle as the optimal. That's with a TR of 5 milliseconds. What if you want to do a TR of 150 milliseconds? Well, you plot the same things into Excel and you get curves. The curves look different though. So here's T. So now let's start again with a gadolinium-enhanced tumor with a T1 of 100. The curve looks like this. And notice that the optimal flip angle is about 80 degrees. Let's now look at T1 200, the surrounding fat. So if you're interested in the fat, then you would pick an optimal flip angle of maybe 70 degrees. And if instead you're looking at unenhanced liver with a T1 of 600, then maybe you would pick a flip angle of about 45 degrees. And now just to show you the difference in scale, on the left is TR5, on the right TR150. So let's draw some conclusions. Conclusions. With short TR, again, each tissue will have its own optimal flip angle. The optimal flip angle increases as the T1 decreases, and in addition, the peak enhancement increases as the T1 decreases. That's on your left. What are we seeing on the right? On the right, we're seeing the same thing, okay? That every tissue will have its own curve. As the T1 goes down from 600 to 200 to 100, the peak, the optimal angle, gets larger and larger and larger, and the peak signal intensity gets larger and larger and larger. Also notice that all other things being equal, you have more signal with a TR of 150 than you have a TR of 5. Those two curves are drawn, these two graphs are drawn to scale. Also notice that all other things being equal, the optimal flip angles when you do a TR of 5 are very low. The optimal flip angles when you do a TR of 150 are much higher. So for any of you who have ever looked at a lava and wondered, with lava I'm doing a flip angle of about 10, and have looked at a dual echo sequence when you have a TR of 150 and there you're doing a flip angle of 70, you've wondered, why do I do a flip angle of 70 with one sequence and a flip angle of 10 with the other? Now you know. If your sequence is a TR of 5, like a lava, you're going to pick flip angles around 10 degrees. If you're doing a TR of 150, you're going to pick flip angles around 60 to 80 degrees. Okay, let's talk about TE. So as you increase your TE, you may or may not increase your TR. If you do increase your TR, then your acquisition time will increase. Let's not talk about that anymore, that's boring. Let's talk about the effect of TE on T2 weighting, on SNR, susceptibility. So, our normal volunteer, showing you what happens when your TE on a T2 weighted image goes from 41 to 82 to 164 to 328. So what can we say? One thing we can say is that your signal to noise goes down. I hope you can all appreciate that this image has lower signal to noise than this image, and this image with a TE of 41 has the highest SNR. So as TE increases, SNR goes down. Point number one. Point number two, contrast. If you're interested in seeing the contrast between a fluid-filled structure, such as the CSF, and surrounding tissues, then you want to use a long TE, right? Look how bright the water is compared to the spinal cord here. Notice that here, harder to tell what's spinal cord and what's CSF. Same thing for the gallbladder. Gallbladder very bright compared to liver here. Gallbladder not as dramatically brighter here. But is it true that a T2 weighted image is more T2 weighted for all structures? And the answer is no. Because if you had to say, can you tell the difference between the liver and the spleen, you would say, geez, the liver looks black, the spleen looks black, I can't really tell the difference. So if you're interested in looking for metastases within the liver, remember, I said the spleen is your surrogate for metastases. So if you said, I want to look at bile ducts and gallbladder, you might want to pick a very long TE. But if you wanted to see metastases in the liver, then you'd look at the spleen and say, aha, maybe I really want a TE of about 41 or 82 in order for the spleen or the metastasis to look brighter than the liver. So your optimal TE depends on what you're trying to visualize. If you're trying to visualize bile ducts or fluid or cysts, use a very long TE. If you're trying to visualize metastases in the liver, use an intermediate TE. Now, this is not a patient that has metastases. This is a patient that has something known as sinusoidal obstruction syndrome. And without knowing what sinusoidal obstruction syndrome is, just appreciate it's a diffuse heterogeneous parenchymal abnormality of the liver. So with a TE of 180, notice that we see the bile ducts really, really well. Notice we see the CSF really, really well. But does the liver itself look that abnormal? It looks kind of noisy, but maybe you'd call this liver normal. But I don't think you'd call this liver normal, and I don't think you'd call this liver normal. You may not know exactly what's wrong, but you would notice that there are some subtle high signal reticulations going through this liver. So what's the teaching point? The teaching point, again, is that your optimal TE depends on what you're trying to image. If you're trying to image bile ducts or CSF or fluid collections, use a long TE. If you're trying to evaluate the liver parenchyma, use an intermediate TE, 70, 80, 90, something along those lines. How about gradient echo imaging? Now, on gradient echo imaging, remember I mentioned in the last lecture that all other things being equal, gradient echo images are darker than spin echo images because gradient echo images lose signal due to two sources of signal loss, random and non-random. So notice that here we're dealing with TEs of 40, 70, 100, 180. Now with gradient echoes we're dealing with TEs of 1, 2, 2.4, 3.3, okay? The reason we have much shorter echo times with gradient echo is that if we really waited for 40, 60, 80 milliseconds, it would be completely black. We'd see nothing. Now this is a patient that has iron overload in the liver and the spleen, but not the pancreas. So notice that there's lots of signal loss from 1 millisecond to 2. By the time you get to 4.8 milliseconds, notice that the liver and the spleen are black. Notice that the pancreas has not decreased at all. So I will now ask a rhetorical question. What is the cause of this patient's iron overload? Multiple choice question. Is it hemochromatosis or isn't it transfusional siderosis? And the answer is B, transfusional siderosis, because we see iron accumulation in reticuloendothelial organs such as liver and spleen and bone marrow, but we don't see it in the pancreas. If we had seen it in the pancreas but not the spleen, we'd be thinking hereditary hemochromatosis. And this is an example of someone who has a different kind of iron overload. This iron overload is due to chronic hepatopathy. So there's three main causes of iron overload in the United States: hereditary hemochromatosis, transfusional siderosis, and now we're actually seeing iron overload due to iron replacement therapy in patients with kidney disease. So those would be the two. And then the third is chronic liver disease. So chronic liver disease that's not due to iron overload can cause iron overload. And this patient has hepatitis C and develops iron overload in the liver, not because of hereditary hemochromatosis, not because of transfusional siderosis, but because she has cirrhosis. At any rate, notice that with a TE of 1 millisecond, the liver looks pretty featureless, but by the time you get to a TE of 8 milliseconds, all of these little siderotic nodules have lost signal, except there's one nodule here that has not lost signal. This nodule is iron resistant, and that is a feature of cancer, and this is a hepatocellular carcinoma in this patient. But what I'm trying to get with this case is look at how the contrast changes between the liver and the lesion with the low TE versus with a relatively high TE. Let's skip this in the interest of time. Okay, so I showed you T1 relaxation curves before. Now I'm going to show you T2 relaxation curves. Tissues that lose signal very slowly have long T2. Tissues that lose signal more rapidly have short T2, and tissues that lose signal very rapidly have ultra short T2. So notice that all other things being equal, tissues with long T2 have more signal, tissues with short T2 have less signal. If we pick a TE that's very, very long, then we will see contrast between very long T2 and some of these other tissues. But notice that we will not see contrast between short T2 and intermediate T2. So with a very long TE, we will not see contrast between the liver, which is short T2, and metastasis, which is intermediate T2. So long TE will give us great contrast between water and liver, but won't give us great contrast between liver and metastasis. So what happens when we decrease the TE? So if our TE goes down, what's going to happen? Well, our SNR will go up. Notice that the signal of everything is going up. And notice that with a short TE, we now have very little contrast at this end of the spectrum, but we have high contrast at this end of the spectrum. So what's the teaching point? The TE that maximizes the T2 weighting depends on the tissues you're trying to separate. If I'm trying to see the difference between this tissue and this tissue, I better pick a short TE. If I'm trying to see the difference between this tissue and this tissue, then I better pick a long TE. So the optimal TE depends on the tissues you're trying to separate. Bandwidth. Bandwidth is the frequency with which we listen to the echo. So do we listen to the echo very slowly, or do we listen to the echo very rapidly? The speed or frequency with which we listen to the echo is called the bandwidth. It's actually a frequency, and it's a very important parameter. When you increase your bandwidth, you may decrease your TE. We can talk about that some other day. If you do decrease your TE, your TR may decrease. If your TR decreases, your acquisition time may decrease. Let's not talk about those things. If your bandwidth increases, your SNR decreases, susceptibility artifacts decrease, chemical shift artifacts decrease, sharpness increase. So let's go over some examples of this. This is important. Starting with this. So what I have here is our volunteer scanned at 50 kilohertz. These are bandwidths, 50 kilohertz, 100 kilohertz, 160 kilohertz, and 250 kilohertz. And what I want to do now is magnify some of these images. Notice that the images are a little bit grainier at 250 kilohertz than they are at 50 kilohertz. So as the bandwidth increases, the signal to noise decreases. So if the signal to noise decreases when you increase your bandwidth, why would you ever want to increase your bandwidth? Why don't we just always image with low bandwidth? Because increasing the bandwidth can increase image sharpness. So here's again our volunteer. Look at the pancreas, bandwidth 21, bandwidth 42, bandwidth 83, and let's now magnify these images. Notice that the pancreas looks blurry here. Notice that the pancreas looks sharp here. Everything else on these images is exactly the same. So sometimes, as a trade-off, you decide, I'd rather have lower signal to noise, but I want more sharpness, rather than having higher signal to noise and more blurriness. Increasing the bandwidth can also decrease the chemical shift. So the chemical shift, there's this black line here and this bright line here, and that chemical shift can be pretty distracting, especially, maybe it doesn't matter so much here, but imagine you're trying to do a prostate MRI and you see all this chemical shift and you're trying to look for subtle tiny little lymph nodes. You're doing a rectal MRI and you're trying to look for invasion through the serosal fat, and you have all of this chemical shift artifact, which is very distracting, and it's hard to know what's artifact versus what's infiltration of the fat. So increase your bandwidth. If you increase your bandwidth, these artifacts go down. So increasing the bandwidth makes your images noisier, but it has trade-off advantages that may be beneficial. Now here's something that I think is pretty cool. With 3D imaging, when you increase the number of slices, you increase your signal-to-noise ratio, because the signal-to-noise ratio is proportional to the square root of the number of slices. Now, I know that sounds crazy, but here, let's look at it. Here is the same volunteer, 3D sequence, 8 slices, 24 slices, 46 slices, 92 slices. I hope all of you agree that this image, this slice, has more signal than this slice. So why would this slice have more signal just because I imaged more slices? Why would this slice care whether I imaged just this slice or 1,000 other slices? Why does the imaging of the other slices affect this slice? Well, you can think of it as the total volume being imaged. When you image only 8 slices, this is what a coronal reformat looks like of those 8 slices. You're imaging very little tissue. When you image 24 slices, you're imaging more tissue. 46 slices, more tissue. 92 slices, you're imaging a lot of tissue. You're getting a lot of SNR. So as you increase the number of slices, you increase the SNR. So why is this relevant? Because imagine that you have a patient that can only hold his or her breath for 5 seconds. You might say, oh, I've got a really smart idea. This patient can only hold his breath for 5 seconds. Let's acquire 8 slices. Well, the problem with acquiring 8 slices is you just may not get a lot of SNR. So you can only cut down on a 3D acquisition the number of slices so much. Parallel imaging. Parallel imaging has powerful effects on image sharpness and distortion. So let's talk about those. Parallel imaging is very important for diffusion-weighted imaging. One of these images was acquired with parallel imaging. One of these images was acquired without parallel imaging. Can anyone guess which one was acquired with parallel imaging? Well, probably all of you have figured out by now that this was acquired with and this was acquired without. But which one has more artifacts? Notice that these images look very clean. These images have terrible artifacts. And again, I don't have time to explain why. We can talk about this some other day. But for now, just be aware that parallel imaging is essential for diffusion-weighted imaging. So whenever you're doing diffusion-weighted imaging, unless it's simply incompatible for some reason, try to add parallel imaging. Let's skip this in the interest of time. And, oh, okay, so I think this is now my second to last slide. This is the table again. We'll talk about the B-value later because we're going to have a lecture on DWI in just a moment. But this table is, again, for your review. We went over many of the rows. I showed you many examples. We all have our volunteer to thank for suffering through 6 or 8 hours of scanning for our educational purposes. We also would like to acknowledge a few people. I'd like to acknowledge Nick Zeverini, who is a physicist in my lab, and Graham Bitter, who was one of my first mentors at UCSD. Nick and Graham have taught me maybe, I may not know much, but what I know, they taught me 80% of it. And the other stuff I learned a lot is from this guy, Alan Elster. So he has a website, he has a book and a website called Questions and Answers in MRI. He's a super bright guy, excellent book. So what I would recommend to you guys who are interested in MR physics is the following. Read Bill Bradley's book. I should have his photo here, I should add it. So read his book, go to Alan Elster's website, and get together with Nick Zeverini and Graham Bitter. After talking with all of them, then come to me and share with me what you learned from them and point out all the errors that I made. So thank you very much for your attention. We'll take another couple-minute break.